Good morning, everyone. After the stable coronary artery disease debate, we have now come back to the ACS, the regular issue that we have more intervention with ACS than with the stable coronary artery disease. See, when we talk of STEMI, we talk of time is muscle. So that makes the program is very time bound. So we need to have a proper network to run the STEMI program. Hello? To run the STEMI program, we need to have a proper network. And one size doesn't fit all. So we have to adjust our network according to our own conditions and situations. The ideal thing is to enhance the speed and delivery of reperfusion therapy to all eligible patients, and continuous audit, adapt to new knowledge, and adjust to local condition. These are the requirements, these are the challenges to meet in any STEMI program. Let us talk about high income countries like America. If we see the NCDR data, it says that 36% treated in less than 120 minutes, only 36%. So STEMI, if we talk of ACS and STEMI, we have to talk of this timeline, the tagline, the time is muscle. So all the program related to, all the network related to STEMI has to be time bound. And we all know that one size doesn't fit all, so we need to work out what works best for you or for your own country. The program ideally is suitable, should be enhance the speed and the delivery of reperfusion therapy to all eligible patients. And this is possible only when we adjust to our local condition, continuous audit, and adapt to new knowledge about how to manage the network. When we look at the time delay in countries, high-income countries like America, only 36% patients are treated in less than 120 minutes. So average time is 180 minutes even in America, and in 25% center, it is more than 240 minutes. So STEMI management for the low income and the middle income countries is still a bigger challenge than the high income countries. Why is it important to learn what is happening in high income country, middle income country, low income country? If you see, the disease is more in low income country than the high income country, and even mortality is more in low income country. So this is very relevant to talk here of high, middle and low income group countries. In India, currently it is estimated, it's roughly estimated that there may be a 3 million STEMI cases every year, that is 30 lakh. Out of that, mortality may be 10 to 30%. Approximately 53% of the STEMI patients travel by ambulance and rest by private vehicle. Out of those who travel in private vehicle, 1 in 300 die because there are no facility. If they have a cardiac arrest, no facility to DC convert them to normal sinus rhythm. There is a registry done called as CREATE registry in India, which is published in the New England Journal, and it says that the average time in Western countries is 130 to 170 minutes for STEMI from door to balloon time. That's what I mean. The CREATE registry suggested in India average time is 360 minutes, which may range from 123 to 1317 minutes. 2 registries have been done, CREATE and Kerala registry, one after the other, and it shows that the PCI rate is improving day by day. The challenges are fourfold. One is cardiac catheterization laboratories are inadequate, mainly located in urban areas. The infrastructure is poor in low income and middle income countries, which makes the access to the invasive center very difficult in the traffic situation, and lack of insurance coverage for all the patients, so the affordability is a big issue. And then comes the outcome. If the patient is not treated by PCR pharmacoinvasive treatment, then downstream mortality, morbidity is very, very serious. So, but the main important thing that currently India's model is pharmacoinvasive 95% of the STEMI. And if you compare the result of primary PCI outcome of the primary PCI and the pharmacoinvasive, the mortality is same, so that is a good part, but MACE rate are little higher. What are the challenges? One is the patient related challenge. Second is a logistic challenge. Third is a healthcare related challenge. How do we solve these actions? These are the choke points. What are the actions? Patient education to recognize this is MI, and we need a social media and other platform to educate the patients, the population. Then we need to sort out the logistic issue by actions like policy changes, investment in emergency services, infrastructure. There has to be a legislation. The government has to approve the STEMI care program so that we get all the help at all levels, and system care. So low cost of the ECG, that is another thing. Centers which are should be available, more centers should be available for MI care, and these are very important aspects for the action, for the challenges to be countered. So total ischemic time is totally depend on patient delay. Patient must recognize that this is a serious event. He should rush to the doctor, he should rush to the cardiologist. Emergency services should be informed about somebody has a STEMI, and the ambulance services, the emergency medical department services should be improved. And then system delay are also there, which we need to talk. So patient need to be able to identify the STEMI, the symptoms, and know how to react to it. That is the most important part. So to reduce door to balloon time, we have to have a strategy. The single call should activate the cath lab, the cardiologist, the cath lab staff should attend the cath lab 20 minutes in advance before the patient arrives, and this can reduce the door to balloon time considerably. It is mentioned in the minute. It goes to about 45 minutes in total. So there is an action plan for 5 players: the patient, the non-PCI center, PCI center, emergency service center, and of course the doctors when the patient reaches to the clinic. So this has to either identify the immediate primary PCI zone, which is in the center, or rapid transfer to primary PCI zone or pharmacoinvasive zone. This is a very important aspect. Any country has to have a map where their PCI centers and non-PCI centers are available. They should have distances mapped properly through the Google map, and emergency services has to be coordinated accordingly. So these are the challenges we are able to see in India. We are finding it difficult day by day, and we are trying to improve on that, and we have created a model which will interact with the STEMI patient in such a way that either pharmacoinvasive or a primary PCI is offered to them in shortest possible time. So there is hub and spoke model. In hub model is a primary PCI center, and then there is a C, which is ECG, less than 30 minutes distance from the primary PCI center or cath lab capable center. And if it is more than 30 minutes, then thrombolysis is ideal, and patient should go for pharmacoinvasive approach, which is currently the practice in India. It is mainly predominantly pharmacoinvasive approach. Now coming to the a model which I showed is created first in Tamil Nadu, is a state of India, and 4 centers were identified and patients were activated accordingly. Has it made any difference? If there is no treatment given and treatment given, thrombolysis, it makes a difference in mortality. Whereas if you see pharmacoinvasive approach and the primary PCI, the mortality is 2%, same, 2%. But MACE rate is little different, but not statistically significant. So what we are showing that action plan, a network which is STEMI network, which is created in a spoke hub model, and it is working and it has improved in certain states. Now 10 states in India are operating for STEMI network on this model. And it is effective. This model is appreciated internationally from the European country and even in America and Canada, that this is a very good model because it reduces the mortality, and even in the country where limitation of infrastructure and resources from the patient side, there is no insurance for everybody. So every time when we talk of this, we see that mortality is reduced. The pharmacoinvasive numbers have gone up. Primary PCI numbers have gone up. In the state, this model is working. So we have a definite advantage in Punjab, Gujarat, Tamil Nadu. And what we have created is a hardware, the ambulance network, the software, and statewide insurance scheme. And 3 models are working. One is classical hub model where patient directly goes to cath lab capable center. Second, if the patient is at the remote area where there is no cath lab center around, then tele-ECG, there is a small device available in India. It costs about 5,000–6,000. It can transfer the ECG to nearby ICU or a cath lab capable center, and they can diagnose and guide the local people how to go about this patient. Tele-CCU model, which is already existing, and this is also very helpful in management of MI cases particularly. And fourth is involving the private hospital in the network. This has worked out very favorably in management of the patient. Now we have these 10 states, which we have 30 states in India. Out of these 10 states have this model working. Other states, we are trying to develop this model, which is very effective. And this development is through mobile app and the web app, so that we can focus on few things like prevention, education, awareness of symptoms of the STEMI, ECG facility, telemedicine, soluble aspirin to be given where the patient delay is there for pharmacoinvasive approach, and preferred is fibrinolysis. And we can also start with a beta blocker because that's supposed to limit the infarct size and improve the survival. And post-MI secondary prophylaxis is very important. So in summary, I would like to say that all players in STEMI network have to work as one. This is a big challenge for any country. Well-coordinated STEMI logistic reduce the time to treatment. This is also another challenge for any country because this requires coordination at night time, and it is very difficult to get enough staff working at the night time. The patient need to know symptoms of STEMI require immediate medical attention. This is where India has to work very hard. This is a bigger challenge because patient doesn't realize that this is heart attack or this is acute myocardial infarction. So every STEMI must be treated with primary PCI, that it should be a standard of care for any country. So to achieve this, it's a big challenge even for high-income group, high-income countries. So it is going to be challenge for middle-income and low-income countries. And thank you for your kind attention. If there are any questions, I would like to answer this.